All right, let's dive into one of the most common and frankly most dangerous electrolyte problems you'll face in the ED, sodium. We're going to jump right in with a scenario you will absolutely see.
Okay, picture this. You're mid-shift. The labs pop up on the screen. Sodium 112, and your patient is actively seizing. This isn't just some textbook question, right? Your next move could literally save their life or cause catastrophic harm. So let's break down exactly what you need to do.
So, before you even think about reaching for saline, your first, most critical decision is figuring out the timing. Is this hyponatremia acute? We're talking less than 24 hours? Or is it chronic, something that's been creeping up for more than 48 hours? This one piece of information changes everything about your management plan. And here's why that's so important. In an acute situation, the brain hasn't had time to adjust, so you can and you absolutely should correct it fast to stop the brain from swelling. But in chronic cases, the brain has adapted. It's gotten rid of solutes to protect itself. If you correct that too fast, you create this massive osmotic shift that is an absolute disaster.
You know, the symptoms line up pretty well with the numbers. If it's mild, the patient might not even notice. Moderate? Now you're looking at things like nausea, maybe some vomiting. But once that number drops below 125, you are in the danger zone. We're talking confusion, agitation, and seizures. Anything below 115 is a true life-threatening emergency.
So let's put this into practice. Here's a classic presentation that you are guaranteed to see on a regular basis. An elderly patient, a history of a fall, a thiazide diuretic on the med list, and a sodium of 122. Your chronic hyponatremia alarm bell should be screaming right now. This is a super high-risk situation.
Okay, so what's the next critical question? It's all about volume status. You can't figure out the cause, and you definitely can't figure out the right treatment without answering this first. Are they dry? Are they overloaded? Or are they somewhere in the middle?
So how do you figure it out? Well, if they're hypovolemic, dry mouth, tachycardic, and they're on a thiazide, their urine sodium is going to be low, and the diuretic is probably your culprit. If they seem euvolemic, but their urine sodium is high, you've got to be thinking SIADH. And if they're clearly hypervolemic with edema, you're looking at things like heart failure or liver failure.
And this right here, this brings us to the number one trap. For a chronic patient, like our 78-year-old, correcting their sodium too fast is the single biggest mistake you can possibly make. I want you to burn this number into your brain. The absolute maximum you can safely raise the sodium in a chronic case is less than 10 millimoles per liter in the first 24 hours. Got it? And less than 18 in 48 hours. There are no exceptions to this rule. Because if you break that rule, this is what happens. Osmotic demyelination syndrome, or ODS. It's a devastating, irreversible brain injury caused by literally stripping the insulation off the neurons. The patient can end up with slurred speech, unable to talk, or even locked in. And the worst part? It is 100% preventable if you just follow that slow correction rule.
Okay, let's totally switch gears. We're going to look at a completely different scenario where all those rules get thrown out the window.
Remember that patient from the beginning? Someone with psychogenic polydipsia who has acutely drunk themselves into a sodium of 112 and is now seizing? This is acute, life-threatening hyponatremia. In this case, going slow isn't safe. Going slow is dangerous.
So here's the game plan, and you have to move fast. First, always ABCs. Then you're giving a 100 milliliter bolus of 3% hypertonic saline over 10 minutes. If they're still seizing, you can repeat that up to 3 times. Now, the key here is your goal isn't to get a normal sodium number. It's just to raise it enough, about 5 to 6 points, to stop the brain from seizing. That's it.
And for that crisis moment when you need to do some quick math in your head, remember this. 100 milliliter bolus of 3% hypertonic saline has about 50 millimoles of sodium. That is a super high yield number that'll help you calculate things on the fly.
Now let's flip the script completely and look at the total opposite problem. A patient with way too much sodium.
So you get a call about a patient with a recent head injury. They're confused, their sodium is 160, and the nurses are telling you they're putting out huge volumes of really dilute urine. This clinical picture should be screaming diabetes insipidus at you.
So what is diabetes insipidus? Really, it's just the body's inability to concentrate urine because of a problem with the hormone vasopressin. With central DI, which you see a lot after head trauma, the brain just isn't making it. With nephrogenic DI, the kidneys are making it, but they're just not listening to it. Managing this starts with a quick calculation, the free water deficit. And don't worry, it's a really simple two-step process. First, you estimate their total body water. Then, you just plug that number into this formula. This tells you exactly how many liters of free water you need to give back to the patient.
But, and this should sound familiar, just like with chronic hyponatraemia, you have to correct this slowly. The max speed limit for correcting hypernatraemia is 0.5 millimoles per liter per hour. If you go any faster, you risk causing massive, life-threatening cerebral edema.
Okay, so we've covered 3 very different cases. Let's boil this all down to the absolute, non-negotiable rules you need to take away from this explainer.
And here it is, your ED sodium cheat sheet. For chronic hyponatremia, your 24-hour limit is less than 10. Your 48-hour limit, less than 18. The biggest pitfalls are correcting those chronic cases way too fast and forgetting to figure out their volume status before you start any treatment. Master these rules, and you will manage these patients safely every single time.
So think back to that first slide, a seizing patient, sodium of 112. The next time that call comes in, you'll know exactly what to do. You'll ask, is it acute or is it chronic? You'll know how to assess their volume, and you'll know those unbreakable rules of correction. You are going to be ready.
Hey, if you found this crash course useful, make sure you subscribe for more high-yield content designed to make you a better, more confident clinician in the ED.